watching The Big Scope, and welcome to yet another edition of Startup Stars. And on the show today, I've got with me Rohit Kumar Pandey, who's the CEO of Sigtuple. So what is Sigtuple all about? And you also have another company, like two companies. So what is it? Is it like data analytics, AI, medicals? What is it that you folks do?
Sure. So at Sigtuple, we are leveraging the power of robotics, data, and artificial intelligence to build smart healthcare screening solution and services. So we feel that the healthcare delivery is underserved, and primarily we feel that there are three big problems: the problem of inaccessibility, inaccuracy, and unaffordability. So through our solutions, we are trying to make healthcare screening solutions more affordable, accessible, and accurate for the larger population.
How is a new age tech like, and when I say tech, I mean the concept was there for a long time, but how, like a robotics or an AI, how does this make any kind of healthcare services affordable? Sure. And what is affordable? Please define affordable for me.
Sure. So in order to apply AI, you need digital data. So when we started looking at pathology and the tests which are being done in pathology, what we realized, the data doesn't exist in digital form. Yes. So if the data doesn't exist in digital form, I can't even apply AI on top of it. So what we did, we started looking for low-cost digital scanners which can help us in digitizing data so that we can apply AI. We couldn't find anyone which was available readily. So what we thought, okay, fine, maybe we have to build something from scratch, because we were looking at solution for emerging markets and it can't be expensive. So hence we created our own solution through which we could digitize any kind of biological sample, and then we apply AI on top of this digital data to generate report. Wow. As far as affordability is concerned, so if you see, the biggest challenge with healthcare is that if you go to tier 3, tier 4 city, you'll not find a lab. Right? Because there are only 19,000 pathologists serving 300,000 labs and collection center. So the samples are shipped from a tier 3 city to a tier 1 city where the processing happens. It includes logistics cost. So the way we have designed the solution, there is no need for the sample to be shipped, because you can put the device in a tier 3 city where the sample can be digitized. The report will be generated on the cloud by AI models, and the pathologist sitting in a tier 1 city can review and approve the report.
Absolutely.
So we are saving a lot on the logistics cost, as well as the solution itself is very inexpensive.
Absolutely. It's two parts. I'll get to the AI, ML and the tech part of it. I'll just take a step back.
Sure.
Now, if I have to really understand this, if I have really my viewers to understand this, you folks, let me put it this way. Say there is a tier 3 city in India and there are just some 10 pathology labs in a city of 1 crore people. For example, I'm just making this up. And there are only 10 pathology labs. Now, there are some 10 experts in each lab. They do the blood test or do whatever kind of test. They get the data on certain forms, say Excel sheet, right? Now, does somebody send the data from that Excel sheet, or somebody scans the data from sheets, physical sheets, and sends it back to you, say in your center in Bangalore, and after that you put those data sets into an ML program? Is that what you folks are doing?
No, that is very complicated.
Okay.
ours is pretty simple. So a technician, not even a doctor, a technician sitting in a lab in tier 3 city, he places your blood slide into our device and press a button called scan on the touch panel.
Okay.
This is all he has to do. The moment he does it, the slide gets digitized. The digital data is automatically pushed by this device onto our cloud. The AI models automatically analyzes this digital data and generates a report. The beauty of this report is it has not only has numbers, it has visual evidence. So when we say that we have counted 100 white blood cells in your blood sample, we show the images of those white blood cells in the report. So a pathologist sitting in tier 1 city, all he or she has to do is open the mobile phone app, look at the number, look at the visual evidence, and click approve. And the patient in a tier 3 city will get the report immediately available in a digital form.
Absolutely. So how is this then? I mean, how is this different? Because you're saying this is AI, but does your AI platform automatically decide and take decision on its own? I decide this is some disease, I decide this is some issue, right? So technically, you're still feeding into data. Isn't it technically still machine learning and data analytics? Isn't this not AI?
So if you see, AI is a big vast term. And inside AI, you have things like machine learning. And then inside machine learning, there is a specialized field called deep learning. So in our entire end-to-end processing, we use both. We use deep learning for classifying various kinds of cells which are found in blood. And then we use machine learning, to come up with the numbers, because at the end of the day, everything has to be converted into half a number for a doctor to understand and give the diagnosis. So we use the power of both deep learning as well as machine learning to come up with this report.
Absolutely. So what is your data setup? I mean, let me take another aspect of it now. The pathology labs in India, I mean, they're the ones where, they're the last ones where I've seen any form of even tech even reach them. So how difficult has it been for you to reach out to them? What were the conversations you initially had with them? And like, you know what, this is what we're doing.
Right.
I mean, all you have to do, as you said, you put a test tube over here and the data comes back there in a machine. Right. So how many pathology labs have you reached out? How difficult has been this conversation?
Yeah, so
explain to them.
The start was extremely challenging. The first thing when we said that 3 com science engineer, we want to solve something in healthcare, there are a lot of people who just smirked at us that have you worked in healthcare industry. So before even we talk about the solution, the background itself was very interesting for them. So we have to go peel the problem layer by layer. So first of all, we generated the trust. How we generated a trust? We showed them a very simple model which can classify a white blood cell.
All right.
When they saw it and they realized that it has been done in an automated manner, they got excited.
Right.
Then we took the next step. We said we not only are doing WBC, we can do red blood cells as well. We showed them we can do platelets as well. And then we can convert everything into numbers. So gradually, the friction which existed because it's not possible, it became exciting for them. Because we are not just throwing numbers, there was visual evidence. This means we are bringing in the transparency. Because if you see the existing device in the market, all they know is that this is a black box. You put blood sample, it will generate some numbers which has to be interpreted. What happens in that box, nobody knows. But here what we are trying to do, we are trying to bring in the transparency so pathologists understand how a report is being generated.
Absolutely.
And that's what gets them excited.
So is this just about pathology or also about, I mean, you collaborate with, you know, these medical institutions? I mean, they sit on a lot of amazing data sets. I've seen so many different types of diseases, so many different types of issues, medical issues. So do you also collaborate with those folks?
Yeah, so we couldn't have done whatever we did just by ourselves. So we collaborated with a lot of pathology labs, hospital chains, a panel of consultants. So 40 pathologists consulted with us to come up with this solution. We got help from big companies as well. So we were selected as part of Google Accelerator Program, IBM Accelerator Program, Microsoft Accelerator Program, and recently we graduated out of NetApp Accelerator Program. So all these big companies, they have their own share of experiences, and they helped us in coming up with the product which can be utilized in the market, which can be scaled in the market, and they provide different kind of guidance, regulatory, intellectual property. So it's not just by us. It's not just by us. The ecosystem was supportive, so that we can grow, we can come up with this product, and it can see the light of the day. Yeah.
Also, interestingly, since you say that in terms of the collaboration, I'll tell you an interesting anecdote. Now, a year back, I would say beginning of last year, I met a lot of medical startups which is still coming up. I mean, this field is still very new in terms of if you see the medical startup industry. Yeah. Now, they told me something really interesting, especially the AI people who are using ML or AI, any such form possible. They said, I reach out to say a particular famous hospital, I reach out to say this famous pathology lab, or you reach out to a particular medical institution. These are people who have actual 30, 40 years of data, how a particular disease has changed or whatnot has happened. Right. Now, you know what, so an AI and ML medical startup is as good as the data that they have with them, correct?
Yeah.
So what I was told, and when I saw, and this is not one or two, there are around some 10, 15 of them, they said, when we reach out to these folks, they said, how can I trust you? Get a starter. How can I trust you with my medical data? So eventually what I saw was like these Fortune 2 or 3 Fortune 500 companies, you know who I'm talking about. Nothing against them, but they ended up getting all these contracts. They ended up getting data on a particular type of medical issue, a particular type of disease. So have you faced that in terms of people trusting with medical data?
You won't believe. We have to go through litmus tests before we signed the first agreement. So we were given, before even a lab agreed to give us data, they said, let's not talk about deep learning at all. This is too advanced for us. Let's talk some basic stuff. So we'll give you lipid profile data for a set of male and female patient. You come up with some analytics and show us what you can do. Let's talk about data analytics first before we go and talk about machine learning. This was the litmus test which was thrown to us. We analyzed this lipid profile data. We came up with this interesting analytics, which highlighted that the reference range, the theoretical reference range, which exists for various kind of metrics out of a test, actually it has undergone a left and right shift. We could show it through data, and that's what got them excited. They said, "Oh, I understand that you guys are serious about it. So let's discuss now. Let's discuss what you want to do with AI and machine learning and deep learning." So this is how it started. The other part which you highlighted that's even more important. It's not just about asking for data and somebody saying that, okay, fine, take my data. You have to go through the proper process. So you won't believe we went to ethics committee where we told them that this is what we want to do with the data. There is no religious bias or any other bias which exists. This is how we will use the data, and this is what we will come up with this data. This was a third-party ethics committee. Once once they gave approval, that's when a lab decided to give data to us, and that too we have to ensure all the checks and balances. It's anonymized. If there is patient consent required, whether it has been taken or not, we did all that before we got the first slide for model training. Yeah.
And also, I mean, what is your data sets? If you can give me a brief overview about what do your data sets tell you? Because whenever people work on data, I get excited because the kind of things that shows up is just fascinating when you take the entire country into question. So, what does your data set show about the standards, the medical standards that we have had in a country, at least for the last 10-15 years, if I would say? What does it show?
So first thing, you will be surprised to know that the way data is stored in various medical institutions, this is not optimal. They don't think a lot. I'm not talking about everyone, but I'm talking about a major section.
I understand.
They don't even think that the patient data which they have, how it has to be stored and what can be done out of it. So first experience which we had was healthcare institutions are not thinking seriously about it.
Wow.
And when we brought this data, that's when we realized, because what we saw that certain fields are missing, certain mandatory fields are missing. It has incorrect values. The values which are absolutely no-brainer, they had those sections or those columns or rows had incorrect values.
Wow.
So when we did a basic analysis just to highlight to a few labs that this is the sanity of data which you had. But after correcting it, when we showcase that what can be brought, just to give you a simple example, that if you have got a CBC test done, can I come up with a risk profile for you that considering that this is the CBC report, what's your risk profile amongst the entire population of Bangalore? We showed them this, that you can figure this out even through basic tests. They were like surprised, right? And they said that, okay, fine, I think we need to think more seriously about the data which we have in order to do something more.
That's how you predict. I mean, I know so many, these doctors and so many students in the medical colleges. I mean, just an hour before the interview when I'm talking this, I know these 3 students who are going through certain jungles in India and rural areas in India, certain parts of the jungle and rural areas, and they're doing a test of, okay, this person has gone through this disease. His forefather had gone through this particular ailment. So what does it say? The gene history and all of that. So also the other aspect of it, I mean, if you look at the data sets that you've collected at your end now you're sitting on some extremely valuable data. Whether I can, if I can put a remuneration tag on it, it's a different thing. But how do you safeguard it then? You have, say, 50 million Indians' data, medical data. How do you go about safeguarding it?
So you're saying safeguard from a patient perspective or safeguard from our own IP perspective?
From your own perspective, IP perspective. Also, you look at, for example, if we just go on to dark web, just go on to the dark web part of the internet, medical data sets are sold I mean, it's sold for more than 3 or 5 bitcoins per data sets of 1 GB. Those are crazy amount of money. So how do you safeguard these data sets at your end?
So 2 things. First of all, the data which we get in our system, it doesn't have any personally identifiable information. We don't bring any PIS. So I don't know whether I have got this blood slide. This belongs to Rohit. This belongs to Sham. I don't know. I only get a unique number. So this means the PIS are with the labs and hospitals. We only get anonymized data, which has a unique identifier. So on our servers, which are first of all secure, there are only data which has anonymized jumbled unique numbers. It doesn't have any personally identifiable information. This is point number 1. The other thing is, of course, we have built security layers across our platform so that people can't access it, people can't misuse the data, apart from using anonymized data. The third thing which you asked around the IP part, this is a myth in the industry. People see that people who have enormous amount of data, actually they are data rich. No. People who has enormous amount of data, with high quality and with annotations, they are data rich. So for example, if I show you an image of a blood cell, if you can't identify whether it's a white blood cell in it or it's a red blood cell in it or it's a platelet in it, it's not that rich. But if I say that this is the image, there are 3 white blood cells, 2 red blood cells and 3 platelets, the quality of the data improves. So it's not just about the volume, also about the quality.
Absolutely. I'll go to that. There's an interesting thing I want to ask you over there, but I'll take one step back. So say, how many employees do you have right now?
Around 110 employees.
110 employees. So are all 110 employees allowed to look at all these forms of data?
Absolutely not. So it's a role-based success. We have implemented something called RBAC, which is called role-based success control. So depending on the kind of role they are performing, and there's a job function, we restrict the access of data. So for example, data scientists will have a different access to data, a platform engineer will have a different access of data, and a regulatory expert will have a completely different view of data. So we have implemented.
What do you mean exactly?
So just to give you an example, right? So the data scientists, they are training models. So they need rich features so that they can train their model accurately. So they need to have that kind of data. But a platform engineer, he has no business as far as features are concerned. He's more interested at how the data is flowing, how it's getting stored, how it's getting retrieved. So he's looking at an abstract level of data, not the granular level of data. Similarly, intellectual property expert, a regulatory expert, they are only worried to understand how the data is being stored. Are we following the regulatory aspect of it? So they're only worried about the metadata of data, not actually the data.
Fair enough. Fair enough.
So this is how, depending on their role, we have controlled the access to data.
So before going forward, I'll take a step back. So but your entire organization depends on how good the data is, right? And I'm talking about medical data. So even if there is one small error, your platform will give a completely negative result. So what do you do to take note of whether this is quality data sets or not? About red blood cells, white blood corpuscles, anything of that. So what do you do about that?
That's a very interesting question, and that's what we have to build a process to ensure that we only bring in pristine, high quality data into the platform. So how we do it? I'll give you a very simple example.
Help me understand both. Inside your organization, also, at a pathology lab somewhere in, say, Coimbatore, who's going to send you the data. So even at that front.
Yeah, so I'll give you two examples to make you understand. So for example, when we got an image, say it's a blood image, right? It has white blood cell, it has red blood cell. Now I don't know that what is the type of white blood cell which is there in this image. So what we do, we have a panel of pathologists. We give this image to all of them and we say, why don't you annotate? Okay. So a panel, I'm not talking about one. This means 5 to 10 pathologists will annotate. What we do, then we see what the majority of them are agreeing to. So if out of 3 pathologists, all three of them, they said that it's a neutrophil, that's only we consider this image and tag it as neutrophil and train our models on. If 2 of them, they are saying it's a neutrophil and one said that, it's not a neutrophil, it's an eosinophil, we discard that data because there is a confusion. So this is how we annotate, and that's the reason the quality of data is improving because it's a validated data, right? It's a annotated and validated data. Coming back to a second point, that if somebody is sending data, say they are not in Bangalore, they're in Coimbatore, how we validate it? So we have trained models which tags the data. So the moment you upload it, it will analyze all the data and it will flag. Just to give a simple example, if somebody is uploading chest X-ray images and it's all dark, blurry, right? The image is not clear, right? So there are models, AI models which we have trained, which will say that this image doesn't pass our threshold, quality threshold, and it will be parked. And the rest will be brought inside. And again, we'll reach out to the partner and say, we couldn't bring in all this data. Can you give us a better data set? So we have done it in an automated manner.
Absolutely. Since we're talking about automation, here's my fundamental problem with AI and ML. I'll tell you, and I'll give you an example. Let me narrate an incident.
Sure.
And I'm going to ask you a question. Around a year back, I was inside this smart car, so to say, driverless smart car, somewhere in some part of the valley, and there's this huge garage system, and the whole test was they were bringing in journalists like, test this smart car, the driverless ecosystem and all of that. So the car, and I was like, okay, something will not happen. Then the guy's like, I have medical insurance, so it's okay. So the car decides to go at the speed of 30 or something. It automatically decides to go straight, then it decides to go right, and suddenly it takes a back and stops. Now they say it's an AI-powered car. Now my question to you is, the car took the decision, the car's AI system or the ML system took a decision on its own, but the engineers had no clue or did not have a logic to why did it decide to do it. So my question to you is, today if an AI platform at your end tells you, as an example, this is a particular trend in terms of a disease, can you quantify it and tell me on what basis has the AI system taken that decision?
No, I think that's a very, very good question, because a couple of years back, it was difficult. People were treating AI as a black box that you throw data, it will generate a set of models which will take decisions. Now there is a new vertical which has started. It's called explainable AI. Because people are looking forward to see why AI model is taking a decision the way it's taking. So for example, just to give another perspective of it, so there are different layers of neurons which are involved in deep learned model. People are able to, what they're trying to visualize, and when we did it, that when a neuron is learning something, a layer of neuron is learning something, what exactly they are learning. So for example, if the model is saying that this is an image of a cat, right, what each layer is predicting, whether a layer might have learned ears, a layer might have learned mouth, face, eyes. So this is a new wing which has started, so that people start believing in AI decisions. It's still not there. I'm not saying that we are there, but you know, a big group of people are just focusing on research so that they can make AI explainable, and we can make the decisions of AI, you know, which can be explained. Hence, if you look at our approach as well, we are not talking about replacing anyone. We are saying that we are trying to empower the doctors. The decision maker is still the doctor. So in our report, when we do the classification and we generate the report, we give this freedom to a doctor that if you are not okay with the report, make a change. And the report will be regenerated. Wow. It's not like we generate a report and we hand it over to the patient. So checks and balances are there, but as technology progresses, you will see that everything will look you know, explained, and the trust factor will
I hope it is.
Yeah, of course.
Absolutely.
It will.
A couple of last things. I mean, help me understand your team. I mean, is it a mix of doctors, engineers, data, and what is your team all about?
Yes.
Understand that.
So it's a very, very diverse team, and even in engineers we have engineers with different backgrounds. So talking about engineers, we have platform engineers who have developed a cloud-based platform. We have mechanical and electrical engineers who have developed the device, including optics engineers. We have microfluidic experts. Then we have data scientists. Then coming back to the non-tech side, if you see, we have regulatory experts, because we need to be focused on the regulatory aspects of it. We have intellectual property expert because we are a product company and we have to file patents. Apart from this, we have a very strong ops team, because ops is also important.
Correct.
And now we have a sales and marketing team too, because our solution are out there in the market. So very diverse team, but the most important part, we have a huge set of doctors working with us. Doctors who have left their cushy jobs, doctors who have left their jobs in big hospitals, and they were so fascinated by our journey that they said, I will join a startup, and they are helping us in building the product, validating the product, clinical trials, each and every aspect of it. And that's what excites us the most.
Absolutely. So what can I expect from you guys in the next couple of quarters? More pathology centers collaborating with you, more hospitals collaborating with you. What more can I expect?
Yeah, so collaboration will be there, because as I said, we can't deliver without collaborating. But what you can expect is that our product is seeing the light of the day. So we will be percolating further in the market. At this point in time, we have started deployments in Karnataka. By end of this year, we'll be pan-India. And then, of course, next year, we have plans to go outside India. Hence, we have applied for US FDA. So you will see more penetration in the market.
Okay. So you're going outside? That's
outside as well.
Where?
So we have applied for US FDA.
Okay.
Once we get the US FDA, we can go to the developed countries as well. So this is more on the penetration side. But what you will see other than that, as our data set becomes richer and richer, you will see much more interesting products coming out of it.
Absolutely.
So it will not be limited to labs. We are thinking of going to clinics, because we have more than 1 million clinics in India. Right?
No, absolutely. So also, I mean, I'm just curious. I mean, since you mentioned about trying to get an FDA license in the US, so why not look at other developing economies per se, because your model works brilliantly with. I mean, I know it's much more easier for you to work, if I can say so. I mean, in a country like US where there are already certified, pathology centers and all that, you have a certain rules and regulations in terms of this is the way you have to store the data, this is the way you have to put certain forms and all of that. So it's more like in an order. So why not go into
no, so we have not applied for US FDA just because we want to go to the US. US FDA is a gold standard for most of the market, be it a developed market, be it a developing market. So if we get US FDA, it just builds the credibility. Now it's up to us whether we want to go to a developing market and developed market. And coming back to your point, of course, we are absolutely focused in reaching out to high volume Asian markets. For example, our neighboring market, Bangladesh. Other markets like Indonesia, right? Absolutely. So of course, our focus is not just to build a product and keep it in India and take it to the US, but cover a majority part of emerging market. US FDA is just a way to build the credibility.
Absolutely, absolutely lovely. It was a pleasure talking to you.
My pleasure. Yeah, thank you.